stressors and the challenges in our experience individually and as part of our social groups. So I'm happy to be here. Domestic violence is an area that I work in, and I chose it because it involves biopsychosocial, spiritual components or inputs that are all involved in the spectrum of healthy, intimate relationships and unhealthy intimate relationships, right? So there's a legal component, political, cultural, social, psychological, etc. So I like analyzing areas pertaining to particularly Black people. I have more knowledge and background in terms of the Afro-American experience and the African diaspora, but I am learning about Indigenous peoples as well and want to expand my understanding. And broadly speaking, I'm wanting to look at what are the mental health issues of us folks who fall in under the umbrella of people of color, and what is the relationship between our status or statuses as communities in terms of health and challenges, and how it interacts or has been caused by, and how we adapt to trauma. Because oppression is trauma, trauma is oppression, right? So oppression is one type of trauma. And so the angle that we'll consider are what are some of the basic ways that those of us under this umbrella were historically traumatized. And at the end of the day, why and how should mental health awareness and treatment, how would that even help us when so much of what we're dealing with is systemic trauma? But I would suggest that, like they say, charity starts at home. Lots of things start at home and start with the individual. So if we can be our healthiest selves, we're in a position then for our communities to be healthier and for us to continue to be strategic and effective in challenging the oppressions. So that's it in a nutshell.
Thank you. All right, and just before we get started too, I just want to ground us in today, before we get to some history. We know that each year millions of Americans face the reality of living with a mental health condition and taking on challenges of mental health conditions. Health coverage and the stigma of mental illness requires all of us. In many communities, these problems are increased by less access to care, cultural stigma, and lower quality care. Mental health conditions do not discriminate based on race, color, gender, or identity. Anyone can experience the challenges of mental illness regardless of their background. However, background and identity can make access to mental health treatment much more difficult. Okay, thank you, Kate. In 2008, to start changing this, the US House of Representatives announced July as B.B. Moore Campbell National Minority Mental Health Awareness Month to achieve two goals: to improve access to mental health treatment and services, and to promote public awareness of mental illnesses among minorities. Next slide. Thank you. So first, I just want us to acknowledge that the way we talk about things can often influence the way we think about them. So we have adopted the term BIPOC, standing for Black, Indigenous, People of Color, when we speak about mental health, because we want to use person-first language when discussing these issues. We must prioritize the identity of individuals as people with unique experiences and identities over their mental health status. For example, we avoid describing people as schizophrenics, and instead we refer to them as people living with schizophrenia. Using the term minority or marginalized sets up BIPOC communities in terms of quantity instead of their quality and removes their personhood. So by including BI, Black and Indigenous, in addition to POC, people of color, we are honoring the unique experiences of Black and Indigenous individuals and their communities. Because BIPOC isn't a monolith. Instead, we have to use intersectional framework when we speak about individuals and communities. Okay, next slide, please. Okay, thanks. All right. And so just to go back to the history of it all and thinking about racism as trauma, we have to think about what is trauma, right? As Dr. Waite was discussing earlier, trauma is emotional response to a terrible accident, event, disaster. It's a response to abuse. And when we think about the colonization of Indigenous people and the enslavement of African people, these are both forms of trauma and racism. These systems involved abuse in order to oppress these groups of people. And there's different types of traumas. So we have a few different examples here. Financial abuse, which would be lack of job opportunity and educational opportunities. Still, people of color experience the wage gap, especially Black women and Indigenous people. And still, people of color are less likely to go to college. For emotional abuse and physical abuse, harm has been done through slavery all the way to today for police violence. Spiritually, colonization imposing religions on people who have their own spiritualities and beliefs. And then there's sexual abuse and trauma, rape, but also thinking of sexual identity and gender identities where people were once highly respected and valued for being two-spirited, and now they face homophobia and transphobia. So this is all the different ways that abuse and racism has infected us today and ongoing. So through colonization, settler colonialism, and other oppressive systems such as boarding schools cause generational trauma and continues to impact us today. Europeans colonized parts of Africa, parts of Asia and the Caribbean, while settler colonialism is an ongoing system of colonization of indigenous peoples and cultures. In the Americas, Native people's children were taken and put into boarding schools, separating child and parents to force the younger generation to assimilate to a culture. So you can see there's been generations of countless trauma. And I invite all of you to come to part 2 and part 3 of our series, where part 2 will be focusing on Black mental health and part 3 will be focusing on Indigenous mental health from people with lived experience. Okay, we can go to the next slide. All right. The reality-based reasons for why there is distrust among people of color in mental health treatment and research. So we want to think back to the Tuskegee experiment. For many of us, we know that this was when the government was intentionally injecting Black men with the Tuskegee virus and it spread through their communities. So, oh, sorry, go ahead, Robin.
Okay, so, okay. The financially challenged sharecroppers who were uneducated, who the government invited for this study, luring them into it, saying you'll get free medical care and treatment for the rest of your life, and so will your family. And these individuals had already had syphilis. But I had to check into this because it gets, over time, it gets muffled. They already had syphilis, but the government didn't say to them, we can give you treatment. At the time the study started, antibiotics had not yet been invented. And just as a sidebar, it was a Black scientist who played a major role in the development of antibiotics, but that's a sidebar. So the Tuskegee experiment went from the 30s to the freaking 70s. It was 40 years because the goal was to see what does syphilis do to the body long term. They knew it was bad short term, but what would it do if you didn't treat it all the way and catch it in the beginning and it went long term? So the men who participated knew they had syphilis, but the lie was there's no medicine for it. And then when the medicine became available, they didn't give it to the so-called participants, and didn't give the participants the option for informed consent with the understanding that they were going to deteriorate. You'll get free treatment, You'll get free medical care, but you're going to deteriorate from this illness most likely, and we won't be giving you the treatment for it. So that resulted in husbands infecting their wives with syphilis, and then children being born with congenital syphilis. And there was a lawsuit and follow-up behind that. So that I'm sorry for the long-winded, but there's kind of some layers to it.
No, thank you. It's been a long day, and yeah, Tuskegee is a place, not what it was. Sorry, everyone. But thank you so much, Dr. And I just want to invite Tracyavon, if there's anything you want to add to anything, please feel free to come off mute and jump in. Okay, thank you. All right, we can go to the next slide. All right. So the importance of cultural competency. The shared belief, values, and experience of any social or racial group can result in different worldviews, have a significant impact on how someone perceives and understands symptoms. For example, a person who has experienced discrimination due to their identity may experience depression symptoms as anger more than sadness. Terminology and understanding of mental illness may differ in communities as well. For example, one study found that white Americans focus on biomedical perspectives of mental illness, while Latinx and African American participants tend to connect mental illness to spiritual, moral, and social explanations. A person must feel comfortable and understood by their mental health professional for a therapeutic relationship to be effective. This includes feeling their mental health professional understands their identity and feel comfortable addressing it openly. When a mental health professional understands that role, that the cultural differences and how it plays into diagnosis of a condition and incorporates cultural needs and differences into a person's care, it significantly improves outcomes. This is why mental health care must be tailored to the individual, to their identity, culture, and experience. And as Tracyavon mentioned earlier, that this is work that she does in cultural competency. So I invite you to go ahead and share.
Thank you for bringing that up. And I think what's most important, and I know we had talked about it earlier when you were playing this in reference to, I don't know if anyone saw on social media, APA, the American Psychological Association, if I'm not mistaken, it was during when Black History Month started. And if for those who follow Twitter or other social media, they had posted the letter, and those of us, in the mental health, community, whether you are providing services or had your differencing of opinion, but it was basically, they were apologizing to the BIPOC or Black or Indigenous community about their practices, right? And when you think of it, the conversations are happening now, which is very important. I do these trainings or I do these conversations often, and I often say, although I'm not that old, as I say, when I was just a couple of years ago, when I was formally trained as a social worker, there were no conversations about cultural competency, about race-based traumatic stress, right? We learned about trauma, we learned about PTSD, right? But it wasn't talking about cultural competency, right? It's important that it's happening now, but when you think of those who make the decisions when it comes to research, right? And when you look at all of these studies, it's not many of us that are either included or that are part of the research study. So for me, I was appreciative, right? And of at least them addressing it, because I think this was the first time, but it kind of also opened the door of, let's look at what's going on when you see of all these studies, how are you making these determinations? Are you looking at bias of those who are doing these studies when it comes to theory, when it comes to diagnosis? And there is, a conversation now that I'm very happy that's starting to come up as far as who gets diagnosed with what, right? And it comes up a lot. As an LCSW, we are allowed, we can diagnose as well. It's conversations when I'm doing clinical supervision or supervision with students, or even in class, because I teach a clinical assessment and diagnosis. And I will intentionally use different case studies to have a conversation like, well, how did you come up with that diagnosis? And we go back to self-reflection, looking at self. How did you live? What was your experiences in life as to why you came up with that diagnosis? We have to really start, for those who are involved in the education piece, of creating an environment where you're really challenging those who want to get into this profession, just looking at yourself and how you're coming up with these diagnoses, right? The conversation about race-based traumatic stress is something that's coming up often. It needs to happen often, because although it's not a formal diagnosis, right? But then when you look at that, why, right? Who puts the diagnoses in the DSM-5, right? It's about always making sure that you are in positions to be at the seat at the table, whether you are a consumer, family member, or someone like myself or Dr. Waite. It doesn't matter. You can be part of that conversation to start changing things. That's where the systemic piece comes from. I can go on a very long TED talk, so I'll yield my time until everything comes up.
If I can give an example of a quick example of what Ms. Ford was saying, historically in psychiatry, Black and brown people are more often diagnosed as schizophrenic rather than as bipolar, because the clinicians view bipolar as the more favorable of the two diagnoses, with the better potential outcome for health, returning to health. And interestingly, bipolar is often represented amongst artists. A disproportionate number of artists who do have mental health problems have bipolar specifically. So there's a certain respect for bipolar that unconsciously gets interpreted as, oh, that person's Black, they gotta be schizophrenic. So I just want to give that quick example.
Thank you, Dr. Waite, because it's a perfect example of what's going on. And it's where we have to be able to consistently have these conversations. But when you're in these communities, or you may know of someone that's in these communities, start to have these conversations, because it wasn't happening before. When you take a step back, there is data that shows in reference to the demographics of, the diagnoses.
Okay, thank you both so much for that. Now I'm trying to figure out where I was, sorry.
The apology.
Yes, the apology, right. That was the next slide. So the apology, you can see, as Tracyavon mentioned, this is what they posted. You can go to that site too. And you can go back, Kate. So before we go forward, I also want to talk about disparities in accessing care. So we lived in a racialized society where the perception of race matters profoundly regarding relationships, access to housing, employment, and services. Therefore, members of racial groups face additional barriers when it comes to receiving care. Some of these include higher levels of stigma within a community, fewer mental health professionals in their immediate area, and fewer providers with similar background who speak the same language. Some people don't have access to care because they don't have insurance, but those who do have insurance still may receive poorer care quality due to lack of cultural competency, language barriers, bias, inadequate resources. This can result in misdiagnosis, dropping out of treatment, and delayed recovery. And I'll just share that, I'm originally from the Bronx, and I moved to Albany. And when I went to a hospital here, I was met with racism, and it was a really unfortunate experience for me. And I started going to a different hospital. So it's something that, it's still happening and still.
Yeah.
I wanted to just add something else to that when you're thinking of intersectionality. I think that's one of the things that's missing when we have these conversations about mental health, right? Conversations about cultural competency and or racism. And it's very important to understand not to ever generalize a community, right? Because first the conversation started to happen, right? And it's like, great, the conversation's happening. And then it was, everybody was overgeneralizing, right? So that you're from the Bronx, I'm from Queens. And sometimes, depending on who you talk to, it's two different worlds, right? Right, with understanding the culture of the Bronx, and you have to say the Bronx, my mother's from the Bronx, right? And understanding what the culture is of queens. So when we are also understanding and looking and supporting communities of color, right, the BIPOC community, you have to understand intersectionality.
Yep.
And the different communities within the communities.
That's right.
That's
right.
very important. That always,
That's right.
I used to go to trainings and I would cringe because there was not one conversation about intersectionality. And I'm sitting in the back, 'cause I'm always the one that's a little vocal, like, hi. You have to. So when you're able to have that, because sometimes you may be addressing a particular community, and because your statements or your recommendations for treatment is so generalized, you're actually offending
That's right.
others in the community.
That's right. That's
so we have to be very mindful of that, always making sure that we're including intersectionality.
That's right.
And also being mindful, right, of our gender, our gender pronouns for in our community. Right. There's been a lot of conversation when you're speaking of, because, and this is just what came in the news when it was saying, you know, as far as like, you know, the Black Lives Matter movement, and you had a lot of trans, right, in the community who was saying Black trans matter as well.
Right.
And we have to also then step back. What is that conversation in, right, the Black and brown community about how we look at trans? So that has to be the multi-layer part of it.
If I can just add an example to that, thank you. That beautifully said. One of the things that Cassandra and I noted when we spoke is that culture is not just ethnic culture.
Right.
There's also socio and economic class culture, right? There's culture of the LGBTQIA, and then subgroups within that group that have their own cultural frame of reference, right? So, so for one example I want to give is that in the Black community, a joke has been, we don't go to therapy, we go to church. However, I am a connoisseur of reality TV Housewives franchise, and I'm here to tell you that the Italian working class women, none of whom have been to college, none of whose husbands had been to college, said the exact same thing.
Right.
We don't go to therapy, we go to church. Okay. So we do have to be, so in terms of therapy, and this is an important aspect, I'm not 100% sure, but I'm pretty sure that on average, those people who do go into therapy on average have higher rates of education. And so it doesn't mean that therapy isn't for everybody. It just means that that group has tended to go in that direction more often. And because of that, we in the field have to reach out to people of all backgrounds, regardless of formal, informal education, and show how this process can be life-altering in a positive way, no matter what your educational background is. So that's part of the challenge here in terms of doing outreach. It's not just ethnicity, it's also education level.
Yeah.
Okay.
I did have a whole presentation, but I'm just we'll just see what happens because I want to touch on that as well. So as Dr. Waite was saying, when we're thinking about why do people go to church, you know, they don't have access to care. Who can they go and speak to? It's you know, their spiritual guide. That's who they go to because they can't afford it. And, you know, when I think about education, I'm the first person in my family to graduate college, and I was the first person in my family to go to therapy. And it's a perfect because of my education, because I have a stable job. And it's something I wouldn't have had if I didn't have those things. So it's interesting to see how that affects, you know, youth of today, as well as we keep going and figuring out, you know, who gets access to care and why they get access to care. And that. So we can move to the next slide, which now I forgot what it is. Okay, stigma and ending myths. Okay. So first, I know we talked about schizophrenia earlier as well, but when me and Dr. Waite were speaking, we saw the statistic that someone with schizophrenia is 14 times more likely to be a victim of a victim of
Violence.
than to be arrested as a perpetrator. But many people have this stigma of thinking of people who are living with schizophrenia as a violent condition. But if the case, anyone can be violent. That has nothing to do with mental illness. Let's see.
Another stigma is that you have to be crazy. If you're in therapy, you're crazy. Maybe we could talk about that for a second.
Yeah, right. Yeah, so thinking, so I don't consider myself crazy and I go to therapy because I have a deeper understanding of myself, and because I have the privilege of the time to do that and explore myself deeper to try to be more successful in life. Everyone has to wait. You don't have to wait for a traumatic incident to happen. You don't have to wait for trauma.
That's right.
You don't have to have a mental health condition. We all have mental health, and we could all benefit from therapy and care.
I think what happens with that is people think mental health is mental illness. So you always have to start with the education of mental health is the same thing as your health. So when you say, what are you doing to make sure that your teeth are in good health? Brushing your teeth, right? And what are you doing to make sure that you don't have high cholesterol? Could be watching your weight or watching your food intake. The same thing is for mental health, right? So sometimes what part of the stigma is people automatically think the minute you say mental health, it means there's something wrong. We have to start normalizing, right? Saying I need to protect my mental health. The same way you wouldn't lay on a beach with no sunscreen on.
That's right.
You really shouldn't, right? You have to start normalizing, saying, you know what, I'm going to pause on X, Y, and Z to protect my mental health. That doesn't mean that you have, right, a mental illness. And you can still live, love, and laugh, still live a normal life like anyone else, right? You can be a CEO, you could be the head of a company, you could be a counselor, a therapist. When you're able to, right, you understand what your diagnosis is, right? So you're getting that psychoeducation, right? So you also understand, even if you have a mental health diagnosis, you still have to protect your mental health. Making sure that you're getting proper sleep, making sure that you're eating the right foods, making sure that you're engaging in healthy relationships, right? That's the same thing for someone, even if someone doesn't have. So it's part of helping the community understand that they're two separate things, and you have to be proactive with your mental health. We all are going to go in parts of life where it could be at one point or it could be low, right? And that's normal. We have to also normalize that you have feelings. We're not robots. You're not flat, right? So you're going to be upset about things. You may be angry at things. You may be like, I can't, frustrated. You may be sad. Something may really bother you. When it starts to affect your ability, as I say, to live, love, and laugh, right? Then you're start thinking about like signs and symptoms, something that's past 2 weeks. So if you're upset about something, but then you're starting to notice, and or your family or friends, that you're still upset about it. It's gone past 2 or 3 weeks, and now your normals are starting to change. So if your normal activity is, I'm going to go on, I go on social media every day and I post an affirmation. And that's something that I do. I love affirmations. Someone would check in with me and like, I didn't see your affirmations. What's going on? Those are signs and symptoms from normal. So I do a lot of the mental health first aid trainings with the National Council on Behavioral Health. And that's what we always talk about. That's part of the trainings, right? Understanding the difference between mental health and mental illness, and signs and symptoms of when our mental health may be declining, right? What those signs and symptoms look like. So when you're going to therapy, doesn't mean that there's nothing necessary. You're being proactive to making sure that you can live and manage, right, life, because there's so many things that's happening, right? And with social media, we have access to things way too quick, right? Especially for young people, which is, and that could be another conversation, but start taking a step back and think about how we can protect ourselves so we're not getting a lot of that mental chatter that we see sometimes, or like the visuals as well. That does affect your thinking and your brain development as well.
Yes, thank you. And actually last year at the education conference, me and Emma, who I think is on, we did a presentation about how to curate a healthy social media feed, because I run our Instagram account and I like to put up a lot of different positive affirmations as well. And I have them hanging around my house.
Yeah.
You can't see them from here, but they're there. Go ahead, Dr. Waite, you're on mute.
So in continuation of protecting one's mental health, do you guys have an opinion about the language of emotional health? Because I wonder if that is something that can be heard more comfortably, that we may not have a major diagnosis, but like you said, we all have emotions, and we can be handling our emotions in a healthy way or in a less healthy way long before we may escalate to something serious.
Correct.
Or not.
Correct.
But a practical example for me is drinking. I think we all know now that there are stages and levels of addiction.
Correct.
Right? So if you catch it, so let's just to make it clean, let's say there's a mild addiction, a moderate addiction, and a severe addiction. So severe is when you can no longer manage your life and it's clear to you. But if we could educate ourselves to be more in tune with what emotional health looks like, you could catch yourself at the moderate level or at the milder level and be in tune with how, okay, I'm using this, I'm drinking to push down feelings that I don't want to deal with. And like Ms. Ford said, we're not even taught we have feelings. This is something very important I just want to say. Apart from trauma, as we think of it as an extraordinary event, right? I got to plug myself in. The other issue is trauma is not just acquired. Uh-oh.
I believe her laptop probably died.
Yeah, I think she was trying to get her plug.
So we'll take a minute and we'll look at some of the comments in the chat while she gets back on. Let's see. We have representation is huge too. I feel therapy is for everyone. Everyone needs someone to talk to. We have some agreements. Exactly, as a counselor and therapist, I believe in my own profession, it's for everyone. Just recently, a young man sought out medical care from a medical facility twice for a manic episode and was denied services and eventually thrown out by security. Oh, I'm sorry to hear about that. Denial of service. Yeah, we have to start making sure that we're getting people access and making sure it's done well so we don't have more instances of like this.
I know a lot of doctors are being, I know doctors, I think if I'm not mistaken, have to take some classes or part of their training. I think they have to do rounds on maybe it's for me watching all these shows on Channel 7, I could be wrong, right? But if I'm not mistaken, someone can correct me if someone's here from the medical profession. You have to do a rounds, I think in a psychiatric ward, but there's now conversations with having medical doctors sometimes either do the mental health first aid training and or just understanding that to recognize like signs and symptoms as well. Because what happens is that sometimes people are having physical symptoms when their mental health is declining and they go to their doctor first. Right. So there are some doctors now who will say, you know what, I think I can recommend, that you speak to X, Y, and Z, or have the nurse help them with their insurance plan to have that conversation. But sometimes it could be having headaches, excessive tiredness, changes in appetite as well. But the doctors are also a part of really trying to understand and have that conversation with trying to get somebody help and to get a referral. Okay, but it's there's nothing wrong. I always say there's nothing wrong with speaking with somebody, right? But we have to, when we're thinking of the BIPOC community, we have to make sure, right, that the therapist of who you're working with is culturally competent, right? You have to make sure that that person understands. And again, culturally competent, right? Although I'm an African-American woman, right? But I may come from a different culture in our community, but part of being culturally competent is understanding that and understanding the culture of the person who I'm supposed to be supporting. And that also cultural competency also means someone's religion, their religious practices, and the cultural norms of their religion. That's also part of it. And that's also, you have to be respectful and understanding when you're working with someone, because also sometimes it means eye contact may not be part of the community. Understanding that and not judging someone, think, well, I'm not connecting with the client. What do you know about the client's culture or their, religious norms? So that's part of the other layers. I think Dr. Waite is back. Yay.
Apologies, everybody. Sorry. Is it okay for me to go back to what I was saying, or?
Oh, yes.
Thank you. So essentially, I just wanted to make the point that as adults, we can be in pain from our childhood, even if we were not physically abused, sexually abused, emotionally abused, or otherwise traumatized or severely neglected at the standard of child protective services. So you can come from an orderly household, an organized household, where your parents fed you and made sure you got your education and made sure you got your medical appointments and cared about you and gave you structure and made you do your homework. But guess what? We still need more than that. We have emotional needs, particularly from birth to about age 5 or 7. It's debated that those core fundamental years are when our personalities are laid down, and they're impacted upon by the degree to which we feel that our true selves are seen by our caregivers, and the degree to which our caregivers enable us to feel safe in subtle ways. So just a quick example, there's a outstanding 2-minute video done at a research center looking at mother-infant interactions, but this can be any parental figure, right? And the point of this interaction was the mother was really annoyed that she had to interact and deal with her child. So they videotaped the interaction of the mother feeding the child, and when it went in fast motion, you saw nothing wrong. When they slowed down the tape to go in slow motion, you literally see the mother's making mean faces and the baby starts to cry. But when it was going fast, you didn't know why the baby was crying. When it went slow, you could see the baby was responding to the mother. So the point is, there are very subtle ways that are not observable from the outside in which infants may emotionally not feel safe by their caregivers. And we take that into our adulthood and we experience it as anxiety. Well, I don't know why I'm afraid to do that, I'm just afraid. Well, that came from earlier on. So I just want to make the point that that type of experience is now being referred to as complex trauma. So it's long-term, it's chronic, and it's very subtle. And it's profound because people get into adulthood and they're depressed and they're anxious and they're like, what the heck do I have to complain about? I had a good childhood. And then they blame themselves for being emotional, not understanding that they were wounded. It just was complex, subtle, and chronic and not obvious. but they get into therapy and then they learn, oh, it wasn't as hunky-dory as I thought. So I just wanted to add that piece.
Thank you. Do you also want to go into the difference between like biological diagnoses and psychosocial diagnoses?
I'll just lay out the framework and then defer to Ms. Ford. Cassandra and I had spoken about the importance, broadly speaking, of some mental illnesses having a strong biological basis and others having less of one and being more psychosocial, coming out of the family life, childhood experiences with people as opposed to the brain. Although we know that there's a mind-body connection and it's not a clean separation, but we want to just broadly say that, for example, back in the 60s, schizophrenia was thought to be caused by a mother's particular child rearing style. And now we realize that it's a biologically based mental illness that usually occurs in the 20s. So that for strongly biologically based mental health conditions, we're talking about schizophrenia, bipolar disorder, and dementia. And then in terms of more psychosocially based diagnoses, not to say there's not a genetic input, but are more so from your experience. We're looking at anxiety and depression and also
Personality
substance
disorders.
abuse. What's that?
Personality disorders.
Personality disorders, substance abuse are more based on how people are reared, nurture over nature. So we just want to make that broad distinction. So let me give you a quick example. You can have a depression. There's about 9 types of depression, okay? So one type of depression might be more psychosocial based, meaning from your childhood, whereas another type of depression may be more genetic brain based. So even though the recommendation for depression is both talking therapy and antidepressant medication, both things, what's been observed is if you have more of a brain-based depression, you respond more quickly and efficiently to the medication and less to the talking therapy. And when you have a psychosocially based depression on your childhood, you respond more efficiently and quickly to the talking therapy and less to the medication. Does that make sense? So that's how I'm trying to make this distinction for us to appreciate. So some diagnoses really, really do require medication, and some less so.
Right, and that's medication, whether it's pharmaceutical or natural, right?
Right, that's right. So we can make the distinction between pharmaceutical medications and what they now call nutraceuticals, which are more plant-based or bioidentical templates of the neurotransmitters that we're low on that might be causing the depression that we take, that's just supplementing the neurotransmitter. What you're putting in your mouth is the neurotransmitter that's already in your brain, and you're building up a higher level of it. So that is an alternative to drugs. So psychiatry is branching out into holistic psychiatry, where they're looking for plant-based herbs and separately and in addition, bioidentical recreations of our own hormones to bring up the levels or down the levels as need be.
And I know we discussed SAME, SAM-E, which is a really interesting substitute, right? That helps with the neurotransmission. Then
It is a neurotransmitter, right? It is a neurotransmitter. And before it was available over the counter in all health food stores under various brands, because SAMe is the name of the neurotransmitter. It's not the name of the brand. SAMe is the neurotransmitter that most people who are depressed are low on. And you take it and you feel better because it increases that low neurotransmitter. But what's important is that SAMe has been shown through clinical research in the United States to be a treatment, an effective treatment for depression. So this is clinically based. And before it got to the United States, Europeans were using it for 2 decades for depression. Back when we were using the old school antidepressants that made you overweight and made you lose your sex drive. And SAMe does, SAMe on average doesn't do that. Obviously, everybody's body's different, but I'm talking about, the side effects on the box that come with pharmaceuticals for antidepressants are not there for SAMe. And America is behind. We're just getting on that.
Yeah, and I'll just mention too, right, that of course SAMe can work for some people, but just like any antidepressant, it's not always.
That's right. And there are other herbal antidepressants, and you may need to experiment, and you should run everything by your doctor.
Yes, and even things like fish oil can.
That helps with brain health.
Vitamin B.
That helps stave off dementia. And I believe the connection between drinking and dementia is starting to, and drinking, also dementia and eating sugar is coming to the forefront. So if we're taking care of our brain, we're also taking care of our mental health.
And I just want to defer to some of these questions in the chat people have been having.
I wanted to add, I don't know if this had came up. I do apologize. I'm 6 feet, so I have long legs and I kicked the plug out from the entire, so the whole setup went dark in here, and my apologies for that. I didn't know if you would, seems like there was a conversation about alternatives.
Yes.
I am a mindfulness practitioner and teacher.
Yes.
And I always like to talk about mindfulness, mindfulness meditation. And there's something that's also starting to come out now with training practitioners on it, or even just teaching that's another way to support someone who may be dealing with ADHD, depression, anxiety, chronic pain, stress, and fatigue. And it's really more of just about helping someone noticing like your thoughts. Everything about what mindfulness is present moment awareness, right? So it's just cultivating and acknowledging that moment that you're in, sometimes teaching breath work or doing grounding exercises. So mindfulness is something that has been talked about a lot, and that's coming out a lot, that where you may sometimes, if you're seeing a therapist, they may be doing some mindfulness activities, or someone even to suggest, just taking a moment and just sitting and closing your eyes, maybe putting your hands on your stomach and just focusing on how your hand feels as your stomach rises and falls, right? One of the misconceptions about mindfulness is that they think that you have to be sitting on top of a mountain at 0 dark 30, as I call it in the morning, saying Om in a yoga position, right? Another thing about also mindfulness, when you're thinking about in the BIPOC communities, there's not many images of us who are practitioners and or teachers, nor are there voices of African or in the BIPOC community that do mindfulness, right? So there's now also a big push, to say, hey, that there are people in the BIPOC community that are trained clinicians and or trained teachers that can do this practice, as well. So it's something that anyone can look up. They have tons of videos that are describing mindfulness, but that's another way to help. If you're feeling like you're having a decline in your mental health and you may not be ready to speak to somebody, you can find like a meditation, a guided meditation video to watch or to listen to, and that can help to settle the mind. So I just wanted to.
Yes, that's
Yeah,
great.
I like
That's
to plug in my
important.
mindfulness wherever I can, because it's a very powerful tool. It's
Yep.
also helpful with grief as well.
Great. Yep, that's very important.
Yeah, thank you. And yeah, as she was saying, you can find them on YouTube,
Mhm.
guided. There's the Calm app,
Mhm.
the what is the other one called?
Mhm.
There's a series on Netflix that just when I was a meditation, when you can watch it on there too, which will guide you through it if you have Netflix. And so right now we are at time, but I want to go through the questions that are in the chat before we end. I know everyone's really enjoying this conversation. I wish we had more time, but I'm sure we can always invite Ms. Ford and Dr. Waite again to come speak with us again. We'd love perspective from
Most
both of you.
welcome.
It's really great.
Yep, my pleasure.
Let's see. All right, there was one. Okay. How can local NAMI affiliates influence the elevation of care for BIPOC community, BIPOC families and individuals in our communities? Do you have recommendations for how to advocate for this? So first, I'll just say, and then, you know, you both can add whatever you think. But so what's happening in certain affiliates like NAMI-NYS metros, they have Black Minds Matter. So there's groups that are particularly, right. So that we have people, so people from the Black community who are leading these groups. And then I want to say in Queens Nassau, they have a Pacific Islander group. So more and more support groups because each of our support groups can be made for populations and for different things. So let's say if there's a large population of people living with bipolar disorder, a new support group just for bipolar. So we can take that same strategy and use it for cultural competency and having people with lived experience, people that you can relate to, you know, lead these conversations so you can feel comfortable with your community. And for example, like if, you know, it's a part of the culture to not make eye contact, then that maybe a place you'd feel safer. But of course, because of stigma, it is more difficult to get into these communities. But my personal recommendation is to start, you can start with faith-based organizations because that's a great way to get into the community. Let's see, and different community organizations, of course, like here in the Capital Region, we're looking to reach out to the Capital District Latino organization and different organizations like that you can reach out to. And just really making those connections, looking at what's right there next to you and asking the people there, what do they need so we can figure it out. Is there a need for something particular? Is there a need for a support group in general? Is it for families? Is it for peers? What exactly do we need and how can we start finding people to volunteer so they can lead these themselves? Because that's our goal at NAMI, to have these support groups led by people of the community.
I'll add also partnering with your elected officials in your area. Most time on like their city councils, they have someone that chairs like a mental health or community committee, contacting them, right? And partnering to see if they can partner with them as well, or also to support your affiliate. It's very important.
Okay, let's see if there's anything else we missed. Netflix meditation. Oh, Headspace. Thank you.
Yeah.
Okay. Stigma's health insurance company will cover. Well, thank you all so much for your comments and for joining us today. And I'll just mention again, so part 2, it will be focusing on Black mental health. Part 3 will be Indigenous mental health. Have people with lived experience on sharing their stories and their stories of recovery as well. So we invite you all to keep looking out for that. It'll be in our e-news. You'll see it on our social media posts. So sign up and come join us again. And hopefully we'll continue the series outside of the month of July, because actually the last one will be the first month of August, and maybe we can continue on. And we're doing our Sharing Hope initiative. So we're going to start having more and more of these conversations. So I hope you all continue joining us. Thank you all so much. And if any of you have anything less you want to throw in or say, please take this time to go ahead. Tracyavon, Robin.
I happen to see something in the chat that LaTanya put, and I think it's extremely powerful and poignant. Said, I believe it's very important to integrate mental health care and physical health care. Therapists should be available in more medical settings. That is correct.
Yep.
This would help to decrease the stigma.
Definitely.
That way you understand is health and mental health should be treated the same.
Yep.
So being able this is where, now it's looking at where can I be at the seat at the table to have this conversation, to say you need to start having social workers right there at the doctor's office, right? Whether it's your local officials or speaking to someone at your medical board, if you know someone's on a board, having that conversation, because that's where the change starts. Because someone's going to go to their physical doctor. Like, I don't feel well. I may not know that I may be having signs and symptoms of depression, but I know I don't feel well, but they're going to go to the doctor. Have the social or have the licensed mental health professional there. So thank you for putting that in the chat, LaTanya. It was very important. That's and I wanted to end with that.
I agree.
Thank you. Is there anything else you'd like to add, Dr. Waite?
No, I'm just I really appreciate meeting everybody, and this discussion is really invigorating and so important that we share information and problem solve. Mm-hmm.
Yeah, great point. And right, creating sustainable solutions too. Yeah, and there's so much that me and Dr. Waite discussed and we did not get to get to. So there's just so much to unpack with these topics. So if you didn't get to hear something, I'm sorry, it wasn't on the agenda, but one session is not enough. So just keep joining us for our different sessions.
Yes.
So thank you both again for joining us, and thank you everyone else. Have a great night and do some self-care today, maybe some mindfulness.
Have a good night, everyone.
Sounds good. Take care. Thank you. Bye.